Welcome to school, right? It feels like we're back to school. Mr. Secretary, will you please take the roll?
Senator Carter.
Here.
Senator Bratton.
Here.
Senator Hudson.
Here.
Senator Nicola.
Here.
Senator Nurnberg.
Here.
Senator Lewis.
All right, awesome. Quorum established. We will now have presentation by Senator Fitzwater on Senate Bill 878. Senator, begin when you're ready.
Thank you, Madam Chair. It was great to be in front of your committee. Appreciate the time. The first bill I have here, I'll be as short as I can. It's pretty simple. I think everybody says that about their bills. It's Senate Bill 878. I'm Travis Fitzwater, Senate District 10. And this is a scope of practice expansion for pharmacists. A couple things involved in it are things that pharmacies see all the time that prevent patients from getting care. One of them, during COVID-19, some rules were removed for them to be able to do flu, strep throat, and COVID-19 type meetings because we just needed access to care for patients in COVID. Surprisingly, the sky didn't fall when the expansion of their practice was allowed, and they took care of patients and kind of filled needs where they were, because obviously there was a lot going on then. So we just want to kind of take those COVID era rules and apply them going forward, which I think is an appropriate thing to do. It also allows trained pharmacists to provide medication therapy services around influenza, strep, and COVID-19, and the ability to prescribe some DME products. And this is the first year I've proposed a scope of practice for pharmacy, so there's some things certainly to be worked out around DME. I think the doctors will come up and talk a little bit about that, but that piece may have a little ways to go, but I think the important piece is that we're providing care in an easy way that pharmacists are already doing. They can do today. They're trained for it, and just give them the opportunity to take on some of these tasks. So I'm happy to answer any questions if there are any.
I have a question. Initially, you just got done saying that they would be talking about the durable medical equipment and what that encompasses.
Yeah, that's right. And it's I think pretty outlined in this too. So I think the Pharmacy Association will come up and kind of talk about what some of those things are that are included in that to just provide clarity. But there are things that are just typical that require prescription. Mask for asthma, some other low-level things that pharmacists certainly should be able to dispense.
Okay, I appreciate that. Any questions for the senator? Senator?
So back when you brought up the COVID, so back with the COVID and the epidemic that occurred, we had to pass legislation because we had docs, and I was on a huge Zoom call. It was a big regional call with numerous doctors around the area with ivermectin that were prescribing it when they were having outright refusal of pharmacists filling those prescriptions. So that's where I guess I hate this muddying of water where we have, these folks that went to medical school for prescribing this stuff. And these guys are going to school for dispensing. So I guess, is that not just like a little bit of, I understand they go to a high level of schooling and training, but I mean, we had to pass a law to make it to where they would fill the directive of the doctor. It's pretty crazy that we have to pass state law. I just want to make sure that we're not going to all of a sudden, expand these scopes of practices where this really isn't the avenue in which. If they wanted to be a doctor, they should go to school to be a doctor, not to be a pharmacist.
The pharmacists are coming out of school now are doctors of pharmacology, so they are doctors.
Yeah, but they're not like
they're not medical doctors.
Seeing the patient. They're not. They're not putting forth the checks and all that like a doctor's doing. Yeah. And that's I just want to make sure. It's not that I'm not for making sure people can get health care provided and it's expanded. That's not my line of questioning. It's just making sure that we're staying in the lane of which you did go to school. So
I get that. And I don't think this is high-level medical care. I think these are things that pharmacists see on a regular basis, and they're delayed to give their patients the things they need by hours, by waiting for a prescription on a face mask or something that they could take care of that they did during COVID. That I think they could do today, and it'd be appropriate.
Okay.
To consider. And this bill's got some it's got some work to do. So we'll work on that and get it to a point where I think everybody.
Now,
happy
like
with
when
it.
they do step into this potential realm, do they have to up their malpractice type stuff? I mean, I don't know. I'm not, but I mean, if you're stepping into no matter what it is, you step into prescribing, saying that this is right for that person. I mean, does that then assume a much greater?
I can't answer that question off the top of my head.
And again, I'm not coming after you.
Yeah.
Yeah, you know that. I mean, these are things that come to my mind.
Senator, you've always been a passionate man, and I'm very aware of that. So it's no problem at all. These are good questions.
Okay, I appreciate it. Thanks.
So I have a question, again, just kind of piggybacking and looking at the scope of this, is these are vaccines and things like that they normally would have to go to either the health department or a doctor to receive, right? So it's not necessarily a prescription, or is
Yeah,
it?
and they're already able to give vaccines. That some of that already happens, and we expanded their scope over
Right.
the last decades on the ability to give vaccines in partnership with a doctor. So they're not just providing them; they have to be connected to a doctor's office.
Okay, and this changes.
This is just some low-level things that we've already seen. So strep throat, the flu, COVID-19 type stuff. There was already an expansion of this in emergency rules during COVID. So we know that pharmacists aren't doing things that are well beyond their ability and their training. They're just doing things that they've done in the past that would be helpful for access to care, especially in rural areas. That it's a burden to get to a doctor and wait several hours for something that a pharmacist could probably dispense with.
Okay, I appreciate the clarity. I know a situation with my son, it was actually the pharmacist. I will say that I think pharmacists know more about medicine than sometimes the doctors do, because they are.
Yeah, they go to school 6-7 years to get a doctor of pharmacology. They're studying it pretty intensely nowadays. The program is incredibly intense, so they are very aware of what goes on in patient interactions with drugs.
Yeah, I always be grateful for my pharmacist who actually redirected us, based on a prescription that I had and took it in. It was the pharmacist that flagged me and said, hey, this is, might potentially want to go a different direction with your son. So I appreciate it. Any other questions, Senator? Yep.
Thank you, Senator. You had admitted that the bill still needs some work, correct?
Yeah, around the DME stuff, I think we need to ensure that we get doctors in a place where they're okay. At any time where you're doing scope of practice changes, you have turf battles that need to be worked out, and I've always been happy to sit at the table and figure out how do we get through those.
Yeah, I appreciate that and your willingness to do whatever it takes to make us feel more comfortable with the bill. I appreciate it, Senator.
No problem.
Thank you very much.
Any other questions for the Senator? Seeing none, thank you, Senator. We will start with testimony with those who are in favor of the bill.
Chair, members of the committee, Henry Telemack with the Missouri Pharmacy Association, to go on record as in support of Senator Fitzwater's bill. I thought he'd be sitting next to me, so I was going to, jab at him, but he's not. So that being said, I'm going to start off with trying to answer where we are and what this bill is trying to do. So in 2023, Madam Chair, your predecessor who had this committee, Senator Thompson Raider, sponsored a Senate Bill 43, which authorized pharmacists to administer all vaccines, excluding 7 vaccines, right? It's Japanese encephalitis, yellowpox, monkeypox, yellow fever, and anthrax, right? A lot of vaccines, 7 vaccines were excluded. Every other vaccine, pharmacists are authorized to administer under their own NPI or their own scope of practice. In that bill was a provision that allowed the Board of Healing Arts and the Board of Pharmacy to create a protocol or allow the Department of Health and Senior Services to create a standing order where pharmacists would be able to provide what is called a clear wave test for COVID, flu, and strep. Senator Thompson Raider really wanted the strep portion in there. Right now, on the federal level, there is something called the PrEP Act that is still active, but it is set to expire, and we don't want to revert back to how things were. Under the clear wave test, there's what is called rapid strep test, rapid flu, and COVID test. Pharmacists are doing that right now. If the PrEP Act goes out, What we would most likely see is a pharmacist no longer being able to do that. It's been 3 years to the day. I can't say 3 years to the day. 3 years to the day that the bill was presented. But after session 3 years ago, the Board of Healing Arts and the Board of Pharmacy have not jointly promulgated these rules. It's no consternation between the groups. I just think boards are trying to hash things out. But in the meantime, patients may fall through the gap if the PrEP Act goes out of place. So, Senator Bratton, you did ask a question about ivermectin. I do remember that. That was then, now Congressman Onder, and you had worked on that, and we got to work with you on it. A lot of what pharmacists were seeing was related to contraindications of medications. You've mentioned it. Physicians are astounding. They go to school for their own practices, their own focus in their study, right? I'm never going to be a brain surgeon. If I ever do, please get me out of this building. But as we talked to then Senator Onder, now Congressman Onder, what we found is those contraindications were concerning to some of the pharmacists, and I think we got to a place where we were able to work out language that allowed pharmacists to dispense those medications when a patient needs it, right? So that is what was then in place and what's in place now. So in Senator Fitzwater's bill is a section regarding DME, durable medical grade equipment. It allows pharmacists to prescribe and dispense those. What those are, and what we're trying to work with stakeholders who have come to the center about, some have come to us, and we've been able to figure out in subsection 1 and subsection 2, subsection 1 says anything that is reusable, right? And subsection 2 says that it has to have a long shelf life or long-term use life. So we're removing those two sections because the aim of the bill isn't to allow pharmacists to prescribe and dispense anything, right? It's those ancillary items like a nebulizer mask that my wife and I know quite often because we have to go get a nebulizer mask for a daughter who has asthma, right? Or a patient who is taking insulin. It's called the pin needles, right? Senator Lewis, you know the term probably better than me. I don't know for the insulin. It's probably the pin needles. That's a one-time use. You use it, take your insulin, then you throw it out, right? And to prevent infections or anything else. So that is what the Senator's bill is trying to do. We're open to working with stakeholders in limiting and allowing the boards to authorize what those DME that can be prescribed and dispensed are. Those who have approached us, we've told them, hey, look, we're open to working with you. We're looking to make sure patients just have a continuum of care and we're not having a gap in their overall services. So that's the Senator's bill. I try to keep it simple because I know he wants to get out of here. So.
Yes, a meeting. So any questions for the witness? Go ahead, Senator Lewis.
Good afternoon.
Hey.
So yeah, I think I would love to talk further. It sounds like the bill sponsor is open. The DME part is new, and that's where I had quite a bit of questions. So certainly looking forward to working with the bill sponsor and the various stakeholders to see what we can do to support our pharmacists because I get my flu shot from my local pharmacy. So, want to be able to help do that, but just want to make sure we're not, there's no unintended consequences. It sounds like that's what everyone's thinking.
Oh, yeah.
Yep.
It's the fun of the process.
Any other questions for the witness? Seeing none, thank you for your testimony.
Thank you.
Next in favor? Next in favor? Go ahead. Hi.
Thank you very much, Madam Chairwoman, member of the committee, members of the committee. My name is Arnie C., AC Dinoff, State Public Advocate. I'm in favor of this. I was in favor of it in the previous years. We're talking about some basic medical care, such as flu shots, strep throat, medical equipment, some of the items that were mentioned by the sponsor. I think that this is really needed. I can give you my personal experience. The last probably couple months, I've put off going to the doctor because I know he's going to ask for tests that are going to cost me several thousands of dollars in copays in terms of a stress test and a full blood workup. with my heart doctor. And so I put it off for about a year and a half. I called and made an appointment, and I ran out of all of my prescriptions actually are going to run out probably next week in terms of blood pressure medicine and cholesterol medicine. And so I'm feeling some results because I'm not taking those maintenance drugs in terms of cholesterol and blood pressure, and it's causing undue burden to me and a lot of issues. My appointment is probably in June, or it is actually June. It's a long way to wait, and I think there needs to be some type of responsibility, and I don't know why the doctor is playing these games. I faxed information to him. I've called routinely to the staff trying to work out some solution, and I'm not getting anywhere. And as a patient, I feel between a rock and a hard place. Our medical issues are getting tougher here in Missouri, and so I believe that this is a good sense bill, the Senate Bill 878, to stand up for Missourians, especially who don't have a doctor within a number of counties across Missouri, don't even have a doctor that is readily available or has an office in a particular county. And so I think that this is going to loop that gap. I'd ask the amendment maker to possibly look at having the pharmacist renew prescriptions if the patient can show that there's been an appointment made, and then with the records of the pharmacist, let's say it's Costco, for example, that's my pharmacy, they would have a record that I've been on these drugs for 6 or 7 years, and they would know that I'm not trying to pull a stunt on them. Of course, they're not narcotics, they're just regular maintenance type drugs. And so I would ask the sponsor to look into that, because I see a real issue here, especially with our economy getting tougher, especially with insurance getting more financial responsibility put on the patient in terms of copays and deductibles. It's making it almost impossible with some of the stress with the increasing costs of our medical system. For those reasons, I fully support SB 878. Thank you, Madam Chairwoman.
Thank you. Thank you for your testimony. Any questions for the witness? Seeing none.
Thank you.
Appreciate your testimony. Next in favor?
Very briefly, Madam Chairman, David Overfelt with the Missouri Retailers and Missouri Grocers Association, and we do support our pharmacies and our stores that have pharmacies. And this bill, we think it would help
All right.
clarify.
Thank you. Any questions for the witness? Seeing none. Appreciate it. Next in favor? Going, gone. All right. Any in opposition?
Madam Chairman, Jacob Scott, registered lobbyist for the Missouri State Medical Association, the Missouri Association of Osteopathic Physicians and Surgeons, and the Missouri State Orthopedic Association. In opposition to the bill, I want to thank Senator Fitzwater for his passion for health care. I know that he wants to do a lot of great things to improve access to care and to improve high-quality care. With this particular legislation, though, I do have a slight concern about the durable medical equipment provisions within the bill. The vaccine language, I haven't reviewed it conclusively, but I think that we're on the right track with that, as long as there's joint promulgation between the Board of Healing Arts and the Board of Pharmacy. On the durable medical equipment stuff, the thing that we have to consider is that physicians and other mid-levels, they're the ones that are actually trained to prescribe medication, including durable medical equipment, where pharmacists are trained to dispense these items. It doesn't mean that there's not an opportunity for pharmacists to be involved in this process. They're an important part of the team that provides care for patients. There's over-the-counter medical equipment that they still do, but a lot of these durable medical equipment devices are quite expensive. They're billed to insurance, and it's best that a physician or whoever's in charge of their care plan is carefully reviewing whether or not they need these types of things. So, we want to support our pharmacists as well, and I think that although I believe that this bill is not really the way to go about it, it's a little misguided, there are things that we can partner on, such as like PBM reform, to help our pharmacies, thrive and continue to serve patients. So I'm happy to answer any questions, and I do look forward. I appreciate the bill sponsor saying that he'll work with us, and I look forward to those conversations to be had.
All right. Thank you. Any questions for the witness? Seeing none, appreciate your testimony. Next in opposition. All right. We're good. All right, that concludes the hearing for Senate Bill 870. Oh, and thank you guys. It's been a while.
Good afternoon, Madam Chair. Hampton Williams with the Missouri Insurance Coalition for informational purposes. I think just to have the opportunity to not have to oppose something sponsored by my friend Senator. But I just wanted to raise a few points regarding how these some concerns, which I think Senator Bratton had raised, that the committee might consider. First is that when you look back at the scope of pharmacy statutes, which is section 338.010, whenever it talks about the ability for pharmacists to, again, I try to extend prescriptions that have already made, there's limitations imposed on that scope of practice. What the current practice statute says is that pharmacists cannot diagnose or independently prescribe pharmaceuticals, and pharmacists cannot promulgate therapeutic substitutions for pharmaceuticals. One of a consideration that might be an improvement to this statute would be to require an accreditation standard for pharmacists to be able to engage in this type of extension on their current scope. The National Association of Boards of Pharmacy includes an accreditation for durable medical equipment. The state board has also promulgated such accreditations to make sure that there's more training involved for the individuals. So that might be an opportunity to address a few of the concerns that have been raised. The other issue, again, is just to reiterate what the Hospital Association had raised too. Durable medical equipment can have expense to it. Our interest is just to make certain that prescriptions, or when it's being implemented or utilized, that it actually meets the needs of the individual. So cost concerns are always something that we're mindful of. Appreciate your time and look forward to working with the sponsor on this bill. Thank you.
I appreciate your testimony. Thank you. Any questions for the witness? I see none. Thank you. That. All right. That concludes the hearing for Senate Bill 878. Senator, we will now hear Senate Bill 970, also by Senator Fitzwater.
Thank you, Madam Chair. Again, Senator Travis Fitzwater, 10th Senate District. This is really going to bring my friends out, this bill. This is Senate Bill 970, and it copay accumulator. Many people know it by. And I'll just tell you, because there'll be a lot of people that come up here and talk about this bill for and against it. I think I translate it to a way for patients who have very expensive care to pay for their care without being penalized for taking care of their care. So my mother has MS. The MS Societies can come up and testify on this bill, I believe. There's somebody here representing them. And if I went and paid for my mom's medication, it would count towards her deductible, and that would be a thing I assume is okay. If I went out and found a pharmaceutical company or some nonprofit that would pay a portion of the deductible and got them to pay on her behalf, that wouldn't count towards her deductible. So she'd be there. That amount of money that she has to pay for her care would not be reduced in what she has to pay out of pocket, even though she went and got that taken care of. So that's kind of like the best way for me to explain it. And you're going to hear all kinds of things about coupons and pharmaceutical companies and generics and name brand drugs, and it's pretty complex how the whole system works, obviously. But I think the important part is that people with very, very sensitive care, figuring out ways how we're not hamstringing them to afford their very expensive care is really, really important. I think a difference also this bill, we carve out unions. Unions have very, very interesting health plans, and so they're not a part of this. They're not, shouldn't be a concern from them, I hope, on this bill. And also, this is for name brand drugs, so it's not for generics. It's the ones that are very unique under, that have patents and are very, very hard to have substitutes for. So It's a unique bill. It's a unique problem. There are several states that already do this. And I think for patient care access, it's a really important change our state can make to make care affordable. And so that's why I bring it before you all. I'm happy to answer questions. Certainly I've had a lot of passionate discussions around this bill in the last year, especially since last year I did attach it to my PBM bill. So I was trying to stir up as many people as I could last year in one big bill, and this time I guess I'll just stir them up on this one. So happy to answer any questions if you have them.
So I do have a question. Have you seen in those states where they do have co-pay accumulators, have you seen a decrease or more transparency or more benefit?
That's a great question. I think somebody who comes up here can hopefully answer that for you. I can't off the top of my head.
Okay, great. No, I appreciate it. Look forward to it. Any questions for the senator? Seeing none, thank you.
And also, I have something I have to be at, so I may escape here in a couple of minutes, but I will stay around for a couple minutes. Thank you.
Sounds
Thank you,
good.
Madam Chair.
So we'll start with testimony or witnesses in favor of the bill.
Hi, hello. Thank you for having me and listening to my story today. My name is Jamie Thomas. Whenever I was 32 years old, my life probably looked pretty similar to most of yours at 32. I had just started a business with some business partners, one of whom is here with me today. I had a 4-year-old daughter and a 1-year-old daughter, and my life was really great. My world turned upside down when I was very suddenly diagnosed with a rare form of multiple sclerosis. Sometimes this form of MS is deadly. It's so rare, in fact, that I was the 3rd case that Mayo Clinic had seen at that time. My symptoms came really fast and were very severe. It wasn't a slow lead up like sometimes MS symptoms are. I experienced periods of partial vision loss, widespread pain, and eventually total blindness. I don't know if you're a parent, I'm sure some of you are, but I'm sure you can understand how heartbreaking it was for me as a parent to feel my children around me. I knew they were there, but not be able to see them. And at that time, I did not know if my vision would return. Still to this day, the thought of not physically seeing those milestones is just, it's more than I can bear. At that time, my 1-year-old took her very first steps in my hospital room as I was going through all of this and trying to figure out my care. By the age of 33, I had spent a full year fighting for my life. I had gone through a treatment at Mayo Clinic. Unfortunately, that treatment failed me. And I say it failed me, I did. My right eye recovered. That's how I'm able to look at you today, thankfully. But by 33, I was facing the 3rd relapse of my disease, and my vision was fading again very quickly. Throughout that year, I had accumulated about $200,000 in medical debt. That was just to receive my diagnosis and initial treatment. That was just to save my life and so that I could be somewhat functional. It was a double blow whenever less than a year later I was facing this again. Thankfully, there was a new treatment option. There was no generic option available to me. This was the only option I had. The out-of-pocket cost to me was about $8,000. That's between the drug itself and the infusion center where I would receive the drug. It's a 2 times a year treatment, so that's $16,000 a year on top of the medical debt that I already had. I'm sure you can understand. Here again, I'm a young business owner with a new business and young children, and the thought of adding thousands and thousands of dollars to my medical debt each year was just overwhelming to me. Thankfully, my neurologist was aware of a copay assistance program through the drug manufacturer, and that program made that treatment possible for me. If that copay assistance had not been applied to my health plan, I would have owed even more out of pocket just to access a life-changing treatment. This bill would ensure that when patients receive copay assistance, they're able to fully benefit from that assistance. There's no cure for MS. I hope sometime in my lifetime there will be, but right now there is not. This is a very real part of my day-to-day. I am very thankful that at this moment I'm not receiving treatment, but I know that that could change tomorrow for me. And I'm starting this whole cycle again. Over time, I have recovered, and that's not to say that I don't face hardships every day from living with chronic illness, because I definitely do. I eventually stepped away from my business, but today I am a real estate asset manager for a real estate investment trust. I'm personally responsible for about $300 million in multifamily and commercial property in Springfield, Missouri. I serve on 4 boards, both locally and nationally. My children are now almost 14 and 10, very active in their life, their activities, their school. All of that to say that had I not had access to those treatments that I desperately needed, I would not be here and contributing to my community in such a meaningful way. I'm grateful for the care that I received for those programs that made the care accessible. They gave me a chance to recover, to be present for my family every single day, and continue to contribute to my community in Springfield. Thank you very much for hearing my story.
Well, thank you for taking time to drive up and to come up and testify and share your story with us, so I appreciate it.
Yeah, thank you.
Any questions for the witness? Seeing none, thank you. Make sure
Yeah,
your witness
thank
form is
you.
left on the table. Next in favor? Just begin when you're ready.
Thank you, Madam Chair. Committee members, good afternoon. My name is Julie Carroll, and I'm an advocate for people suffering from cystic fibrosis because I'm one of those 800 people in Missouri that fights this disease. My monthly medication cost is $26,000 a month. Luckily, I am retired from state government and Medicare, with the Medicare package for retirees. My medication is paid for with a $100 a month copay. But I do deal with people, and that's why I'm an advocate of other people with cystic fibrosis who do not have the benefits that I have. So I'm here in support of Senate Bill 970 to ensure all copays count in Missouri. I strongly urge you to support this bill to protect Missouri patients from unfair and harmful insurance practices. Patients are often led to believe that they've met their cost-sharing obligations only to be hit harder with unexpected, unaffordable bills. This practice undermines the purpose of deductibles and places patients at serious financial and medical risk. When copay assistance does not count, patients may be forced to skip doses or stop treatment. Families face medical debt or financial instability. Health outcomes worsen, often leading to higher long-term health care costs. This is happening right now to patients in Missouri. I respectfully ask you to support this legislation and stand with Missouri patients, caregivers, and families. Ensuring that all copays count is a common-sense, patient-centered solution that promotes access, adherence, and fairness in our healthcare system. Thank you for allowing me to testify.
And thank you for taking time to come up. Any questions for the witness? Seeing none. Thank you. Next in favor?
Madam Chair and committee members, thank you for the opportunity to testify in support of Senate Bill 970. I apologize for my voice. I'm not contagious. I think I just talked too much. My name is Gabby Flores, and at 14, I was diagnosed with a qualitative platelet dysfunction, meaning that my blood doesn't clot like the average person. To put this into perspective, prior to my diagnosis, I had a 6-month-long period. As a 7th grader, I bled every single day for half of a year. My parents and I fought for 3 years to get my diagnosis, and it took another 6 for me to find a combination of medications that would control my bleeding. But in that time, I had countless bleeding issues and even had to give up my full-ride soccer scholarship due to health risks. My 10 milliliter vial of medication contains, my 10 milliliter vial contains 3 days worth of medication for me, and it costs $860. Without access to this medication, my quality of life drastically declines. I sit here today as a representative of not only the bleeding disorder community, but also those living with chronic conditions. According to the CDC, 6 in 10 Americans currently live with one chronic condition, and 4 in 10 live with 2 or more. Copay accumulators directly impede a patient's ability to receive essential and often life-saving medical care by placing an unnecessary financial burden on the patient. Studies have shown that 80% of Missouri health insurance plans contain these caps. The insurance companies will sit here and tell you that copay assistance programs drive us to higher cost drugs, but 99.6% of patients utilizing these programs have no generic alternative. In many cases, we are really lucky to have one medication available to us. We are not asking you to lower our drug prices. We are asking you to prohibit insurance companies for charging us twice for them. By allowing these programs to exist, you will be putting more money into the pockets of insurance companies and taking life-saving medication out of the hands of patients. 60% of the population is living with a chronic condition and is at risk of falling victim to these predatory programs. By that logic, at least 4 of the members of this committee should be able to relate to our struggle. Understand that accumulator programs, like chronic conditions, do not discriminate and can fall onto any of us at any time unless you pass legislation like Senate Bill 970. This committee has the power to do something that very few can, which is to make living with a chronic condition substantially easier. Thank you for your time. And I have sources for all of my statistics if you're interested.
Yeah, we would be interested if you could give that to the secretary. We'll make sure that that gets dispersed among the committee. Thank you, Gabby, for coming up and sharing your story. Any questions for the witness? Seeing none, thank you again. Next in favor?
Hello, Chairman, Committee. I am Bridget Tyree. I am the Executive Director for Gateway Bleeding Disorders Association. Thank you for voting this out of committee last year. I testified last year. I think you understand the issue. My son has hemophilia. I run an organization with over 400 families in Missouri with hemophilia and von Willebrand's. I run the coalition. We have support letters that were distributed. There's currently 22 organizations that are supporting this legislation. I'm here to clear anything up. The union, some of their lobbyists will come up and say that it affects them. This only affects state-regulated plans. The unions, carpenters' unions, they're on a self-insured plan, does not regulate a self-insured plan. That information has been misunderstood or maybe miscommunicated. These only affects state-regulated plans. There are 7 out of 8 of the plans have accumulator adjuster language in them. It is not a coupon, it's an assistance program. We're not getting a discount on our drug. My son has insurance, he's gone through all the pre-authorizations, he's paying the same cost, he's not getting a discount. It is an assistance program when they use these programs. We do not have a generic alternative, and so I'm here to just answer any questions that possibly may come up or maybe you've heard.
All right. Thank you, Bridget, for your testimony. I'm assuming that you're the one that brought us this information that we all have.
Yes, and I do have I can email you. You had asked about premiums going up. So there's 26 states that have passed this legislation. New Jersey just passed this week. And HIV did a analysis and a study, and they looked at the states that had passed the accumulator adjuster programs, and they looked at premiums, and there was no cost increase. And I will be happy to send that out when I get back to St. Louis. I took an earlier flight from Phoenix to be here to testify. I left my conference early because this is so meaningful to the people that I serve with bleeding disorders, with MS, with Crohn's, colitis. It goes on and on. I don't know anybody that doesn't know somebody that doesn't have something on this page.
All right, thank you. Appreciate your testimony. Any questions for
Senator
the witness?
Lewis.
Yeah. Senator Lewis?
Thanks. Good afternoon. Sorry you had to go all across the country to be here, but thank you for being here. I know it's short notice, so we've seen lots of different types of bills that, like the senator pointed out, he had a bigger bill last year and kind of scaled it down. So when you talk about the 26 states that have passed this, is it identical to this bill, or because there's like transparency bill, there's so many different kind of, I guess, avenues or ways to go about addressing some of the costs with healthcare. So I just want to be very clear with the 26 states that have passed legislation. Is it identical to this legislation?
I can't answer that because I haven't looked at all of them, but I have a copy of all of them on one document that I'd be happy to send because I work with the All Copays Counts Coalition, so I will make sure the committee gets both of those.
Yeah.
It lists state by state what their bills are.
Okay, great. That'd be great. Thanks.
Thank you.
Appreciate it. Any other questions for the witness? Seeing none, thank you for taking time to come.
Thank you.
Safe travels. Next in favor?
Emily Kalmer, American Cancer Society Cancer Action Network. Similar to the experiences you've heard from other patients, cancer patients often face this same issue, particularly because many of the newer cancer drugs do not have generic equivalents as well. When they receive copay assistance, we want that copay assistance to count toward their out-of-pocket costs so that they can continue to afford their medication. I've testified on this bill many years. In fact, when I was revising my testimony for this year, the first year I testified on it, there were 16 states who had passed similar legislation. Now we're up to 26. And that's only been a few years ago. So we don't want Missouri to be left behind. Some of the common arguments we hear against this is concern about the impact on premiums. As Bridget mentioned, we've not seen that be the case. There's been a number of analysis about that. We want people to be able to afford premiums so that they can get access to health insurance. So that's something that we look at before we get engaged in legislation like that, and that's not something that we've seen happen. And we have supported this in a number of states, including, as she said, New Jersey recently. Some of the other arguments are that this is a mandate. We are not mandating coverage of any particular drug. We are saying if your doctor prescribes it and it is the drug that you need and there's no generic equivalent, so there's no steering to a particular drug, then you should be able to use funds that are provided to you from a nonprofit or a copay assistance program and have those count towards your out-of-pocket costs and deductibles. Right. So if you have any questions, I'm happy to answer them.
Thank you, Emily. Any questions for the witness?
And I just want to mention Joan Gummels, who is a cancer patient who has had this happen to her. You may be aware of her. She used to work around the building. She submitted online testimony because she wasn't unable to be here today.
Okay, appreciate that. Thank you.
Thank you.
Thank you for testimony. Next in favor?
Madam Chairman, members of the committee, my name is David Winton. I'm here appearing on behalf of Pfizer and Novartis, two pharmaceutical manufacturers. And I want to just talk just a couple of minutes about essentially why we're here and why we're testifying. So a lot of the programs that we're talking about, copay assistance programs, are sponsored by these companies. In fact, $23 billion annually goes out to patients, and they go out to patients to help them afford their copay. Everybody understands that affordability is a massive issue in healthcare. There's absolutely no question about that. And medications are expensive, healthcare services are expensive, everything's expensive, and we understand that. And I know you all understand the things that go into creating medications is not simple. And it often takes years, and we have lots and lots of failures to get there. And so I can't speak nearly as eloquently as the witnesses before about what this really means to a patient in general. So I thought I would just tell you a couple of the facts about like what these programs are used for and how they work. So all of these programs are, and every pharmaceutical company has these programs, so do most of the folks that you heard from earlier from the cancer, all the foundations on disease states. So folks that are struggling to afford their copay because we have such high deductibles now in insurance policies, you know, if somebody is unfortunate enough to be afflicted with a disease that only has a single medication available to it, those medications are going to likely be expensive because they're probably still on patent and they're probably still kind of earning through that process. What these programs do is it helps folks not become have-nots for medication. So if you have a $5,000 copay staring you in the face and you're taking a medication that costs $2,000, $3,000, $4,000 a month for cancer or lymphoma or any disease that you have, what we have tried to do really hard is say, you shouldn't be out of the drug because you can't afford your copay. They also apply to people who are uninsured. All these programs are available to folks. They are done on a sliding scale based on somebody's income and how much they make. And so these companies are putting a tremendous amount of money in, understanding that's what it is. The only question is whether or not that money goes to the benefit of the patient or it goes to the benefit of some other entity. And so in this case, what we are saying in this bill is that money that goes to the counter at the pharmacy has to go to the benefit of the patient from the standpoint of deductible and meeting that deductible. And that is hugely important, or else that individual never meets their deductible. And every time they have a health care need, every time they have to go in for a CAT scan, they're going back, and it's $5,000. So what we're saying is we're happy to put that money in so the haves and the have-nots are not, we don't have a lot of have-nots when it comes to medications like this when people can't afford them. We try really hard. Doesn't mean we hit everybody. And we would love for the insurance companies, we would love for the PBMs to also donate large sums of money to make sure that their policies, and by the way, insurance companies can do this right now. They can do no deductible by just waiving the copay for people that can't afford the copay and not get stuck. I appreciate all the time that you all have given us in this process. Appreciate the early hearing, and I appreciate the consideration. I will also say that all of the avenues legally available to an insurance carrier to make sure somebody's on the correct medication exist in this bill. They're reiterated: step therapy protocols, utilization reviews, all the things that we expect them to be able to do exist. We are not telling them they have to cover a drug that they don't cover today. What this says is if they've already agreed to cover a drug, they can't tell you where to get your money for that copay. That's it. It's not their business. So appreciate the time. We'll get you information on those 26 states, but I'm almost positive those states are very, very similar. This bill may be a little more limited because we specifically take labor union policies out of the bill. It is specifically taken out. Most of the other states, that's not the case. That's never been an issue in those other states. So here it is. So we've just taken them out because the members of those unions, they participate in those healthcare decisions. They're on those. That is very unique, very different. And if that's the course that those individuals want to take, then so be it. Thank you so much.
Thank you for your testimony. Any questions for the witness? Seeing none.
Thank you.
Appreciate your time. Next in favor.
Good afternoon, Madam Chair, members of the committee. My name is Rachel Bauer, registered lobbyist here on behalf of the Missouri State Medical Association and the Missouri Association of Osteopathic Physicians and Surgeons. We just want you guys to know that Missouri physicians want their patients to comply with their care plans, and we know that cost is a barrier, and we believe that Senate Bill 907 will help Missouri patients get the care that they need.
All right, great. Thanks, Rachel. Any questions for the witness? Senator Lewis?
I just have a question. Do you and your colleague flip a coin who gets to be good cop and bad cop?
Yes, absolutely.
Any other questions? Seeing none, thank you.
Thank you.
Next in favor.
Good afternoon, Chairwoman and committee. Thank you for allowing me to speak. My name is Angela Brown. I am here on behalf of Missouri individuals and families, including my own brother, son, and daughter, who live every day with a bleeding disorder, conditions like hemophilia and von Willebrand's disease. These are lifelong genetic disorders. There is no cure, as it's been stated before. They don't take breaks, and for families, neither do the medical bills. For people with bleeding disorders, access to medication isn't optional. It's really a survival. Factor replacements, the medications that we take for bleeding disorders therapy and other treatments, prevent spontaneous bleeding, joint damage, disability, and life-threatening emergencies. Without consistent access, a simple fall, dental procedure, or childhood playground accident can turn into a medical crisis. That's why copay accumulator programs are so harmful to our particular community. Bleeding disorder medications do cost thousands of dollars. My son racks up around $30,000 a month. When he orders his medication at the beginning of the year, he automatically meets his deductible, out-of-pocket max. We do our darndest to try to save money throughout the years to pay as much as we can to apply towards that, including or in addition to our over $1,000 now premium that we pay monthly just to have insurance. It's said before, again, there's no generic form of the medication we call factors, and no family, or no matter how responsible or hardworking, can absorb that kind of cost on their own. Copay assistance programs have long been a critical bridge, helping us, individuals and families like mine, afford treatment while still meeting our insurance deductibles and out-of-pocket limits. Copay accumulators quietly take that bridge away. Under these programs, insurance companies accept the copay assistance but refuse to count it toward the patient's deductible or out of pocket. Families believe they're doing everything right. They pay their monthly premiums, they fill their prescriptions, they follow their treatment plans. Then suddenly they're told they still owe thousands of dollars because money that the insurance company received from a third-party payer doesn't count. It's not applied to their insurance deductible or maximum out of pocket. For a family with a child who has a bleeding disorder, this isn't just stressful, it's actually terrifying. Parents are forced to ask impossible questions. Do we delay treatment and hope that there isn't a bleed? Do we skip doses to make medications last longer? Do we take on debt or even realistically pay it off? No parent should have to make those choices to keep their child safe and alive. Copay accumulators don't lower drug costs. They don't make the system more efficient. They simply shift financial responsibility onto families and patients who already carry the weight of managing a complex medical condition every single day. The consequences don't stop with families. When patients can't afford treatment, they end up in emergency rooms and hospitals, settings that are far more costly to the healthcare system than preventative at-home care. Accumulators don't save money in the long run, they just move costs downstream while causing real harm. This committee focuses on children, family, and health. I can't think of a clearer example of where those three intersect than a child or a person with a bleeding disorder whose access to medication depends on whether their parents or their care providers withstand an unexpected financial setback. Other states have already taken action to ensure when a patient pays for medication, regardless of where their payment comes from, it counts toward their deductible and out-of-pocket maximum. These policies don't eliminate insurer tools, they simply restore fairness and transparency. Health insurance should protect people, not penalize them. It should promote stability, not uncertainty. And it should never stand between a person and medication that provides life-saving treatment and care. I respectfully ask on behalf of my family and the other bleeding disorder community, friends and relatives and acquaintances that I know, to support SB970 and move it forward. It provides needed consumer protections around cost sharing under health benefit plans and will help ensure patients, especially those with serious chronic conditions, have access to the care and medications they rely on. Thank you for your time and attention.
Thank you, Angela. How old is your son?
He's actually 24 now.
Very good. And where do
My
you
daughter's
live?
9. She's genetic or been diagnosed as a carrier, so this will continue in our family.
9 years old.
Mm-hmm.
And where do you live?
Ozark, Missouri.
Very good. Well, thank you for taking time to come up.
Thank you.
And testify. Any questions for the witness? Seeing none. Thank you again, Angela. Any next in favor?
Chair, members of the committee, Jessica Petrie-Telemuck here on behalf of the Reach Healthcare Foundation and the National Association of Social Workers Missouri chapter. We support this legislation because studies have found that in other states that have passed the same or similar bills, the rates of medication adherence increase, which means that patients are getting the care they need, which is improving their quality of life and making it less likely that they're going to be hospitalized or end up in the ER. So we view this as an affordability mechanism to make sure that patient assistance actually goes to those vulnerable patients. I am not Will Mars, but I do have his witness form because he got trapped in the governor's office. So I'm delivering that too on behalf of Mercy.
Thank you.
Thank you.
Any questions for the witness? Seeing none, appreciate your testimony. Next in favor?
Thank you, Madam Chairwoman, members of the committee. My name is Arnie C., AC Dinoff, State Public Advocate, and I'm in favor of SB 970, making sure that out-of-pocket expenses, whether they're generic or other drugs, that they're a final contributor to insurance deductibles. There should be no caps on medicines. We're talking about people's lives here. And I think insurance companies are becoming greedy as we go along our economy. It's getting tougher and tougher for Missouri citizens to meet their number one priority of pharmaceuticals or prescriptions. Unfortunately, insurance companies, like I said, have become greedy. It's The bottom line is profits. And in my opinion, sometimes they throw Missouri citizens out the window, and they don't care. And that's not in all cases, but in a lot of cases, the bottom line is profits, and that's unfortunate. Profit shouldn't come into play when we're talking about people's lives, people's chronic conditions, and if there's a medicine that can help them or make living daily life better and more compassionate, we need to do that. Insurance companies need to learn mercy and compassion. I sat back there and thought a lot about this. It breaks my heart. It makes me want to cry. Makes me want to fight for every citizen out there that needs these drugs and these prescriptions. It's unfortunate the Missourians have to have the stress and the not knowing where the next prescription and the next medicine is going to come from on their backs and their shoulders for them and their families. I'm sure after myself, or if there's more proponents for this bill, you're going to hear the proponents against this bill, and there'll probably be a litany of lobbyists, paid lobbyists, paid lobbyists, paid lobbyists, who make a handsome salary from insurance companies are going to come up here one after another, and they're going to be opposing this bill. It's unfortunate that we're not putting Missouri citizens first, and I think it's time that this is one bill in which you as elected officials who are elected by 225 to 250,000 Missourians, it's time that you put Missourians first over insurance companies and especially over profits. I'm sick and tired of hearing profit, 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 profit. The heck with the Missourians, the heck with the Missourians. You don't matter, your life doesn't matter, your family doesn't matter, and we don't care about compassion and mercy. For those reasons, I ask that you fully and unanimously pass SB970. Thank you, Madam Chairwoman.
Thank you for your testimony. Any questions for the witness? Seeing none, appreciate it. Next in favor?
Thank you, Madam Chair, members of the committee. Megan Howerton here on behalf of Mosaic Life Care. Just quickly wanted to throw our support for the bill. Thank you.
Thank you, Megan. Any questions for the witness? Seeing none, thank you. Next in favor?
Chair, members of the committee, Henry Telmach, back before you again. Sorry about that. With the Missouri Regional Boot Heel Consortium, to go on record in support of Senator Fitzwater's bill, we serve some of the most impoverished areas down in southeast Missouri. As the witnesses before me have said, adherence to medication is necessary, it's vital, and ensuring that patients have access to life-saving medications is quite important. So just to go on record is in support.
Thank you. Any questions for the witness? Seeing none. Appreciate it. Next in favor?
Good morning, committee members. I want to thank Senator Fitzwater for bringing this forward. My name is Tyler Travers, registered lobbyist here today on behalf of the National Alliance for Mental Illness, Missouri, NAMIMO. And our members throughout the state, of course, have varying prescription requirements that can be very costly, and we believe this bill would help our members.
Thank you. Any questions for the witness? Seeing none. Thank you, Tyler. Next in favor? Okay, we'll begin those. That will end those in favor. Any in opposition?
Good afternoon, Madam Chairwoman. Hampton Williams again with the Missouri Insurance Coalition. Speaking in opposition to the bill today, we're all worried about costs. We appreciate that there are upward pressures. A lot of it comes from the rise in the costs of the pharmaceuticals themselves, and that's something that our members, our businesses deal with on a daily basis. And so when we're talking about these copay accumulators of this issue, one of the things that we'll discuss are the prevalence of this issue. 88% of brand drugs currently with coupons have generic therapeutic or biosimilar alternatives. Alternatives are available. The issue with this bill and bills like it is that it is invading the ability for insurance carriers to develop formularies to actually determine, I should say also pharmacy benefit managers, to drive costs and pass benefits on to either the businesses or the ratepayers. This is a key market concern that any PBM or ultimately consumer has. It's one of the best tools that we have to try to drive value to the consumer. And so that's the concern about this bill. One thing, when I was researching this issue, I learned that, in fact, these coupon programs aren't permitted for Medicare or Medicaid. Why is that? Well, when the federal government designed their programs, this type of scheme is prohibited by the federal anti-kickback statute. The federal government determined that the use of these types of coupon programs exacerbate the use of expensive brand drugs over cheaper generics or alternatives, increase costs of members. Now, there are some exceptions to the federal program, but generally, this is not something that the federal government allows. And so why is it that we're going to look at our private carriers, private businesses, and say, well, you have to expose yourself to that? That's a concern that we've got going into this. Again, I'm happy to work with the senator on these bills, and there's certainly going to be work that's done on this. The concern generally is that this is as much of a marketing scheme as it is anything designed to help ultimately patients. Instead of donating $26 million to a coupon program, the pharmaceutical company could reduce the price of their drugs. That's an alternative. That could happen. That's what the negotiation process in the development of formularies identifies. And then when a brand name drug does not have the lowest price for a therapeutic or anything else, then if you are the brand name B, you develop this coupon program to get around that formulary. And so that's the general market and condition that we're trying to address. This bill would inhibit that ability for particularly PBMs to try to drive and negotiate those costs in a favorable fashion. And we look forward to working with the bill sponsor on trying to the best of our ability, address these concerns in a way where ultimately consumers are not going to end up exposed to higher costs.
So thank you for your testimony. I have a couple questions. So we were told that we've gone from 16 states in the last few years to 26 states. So if it's not federally approved, how is this passing in other states?
It's specific for Medicare and Medicaid, so these are federal programs. So right now, the only thing that we're talking about deals with, commercial programs. These are programs that businesses are using or anything else. So for our federal programs, there's usually disclaimers. When you get these physical coupons, there'll be a disclaimer that says, this might not be eligible for a federal program.
So how is it functioning in the 26 states that it is implemented?
I heard that as well, and I suspect, kind of like last year that I did with prior authorization, I imagine I'm going to be spending quite a bit of time analyzing the difference between those states' bills and this one as well. So I will look into the mechanics of that program. It does sound to me like some of those have been recently passed, so I doubt that there's actionable market data. I will say, and unfortunately, we generally heard about upward price pressures on health insurance and things like that. I'm unaware of anybody who's in the nation that has, health insurance that's where we're seeing lower rates places, but again, I'll be happy to try to provide as much market data in the states that have tried to implement this and see if I can get that information to the committee as well as the sponsor.
All right, I would appreciate that. And if you could, I appreciate sharing that with us, and we look forward to a conclusion. Any questions for the witness? Senator Bratton?
So I guess where my mind goes when you're bringing up the federal programs, Medicaid, Medicare, I mean, are the people that are recipients of that, do they have copays?
Well, they do pay copays, yes.
But I guess in the terms of how large comparative to what we're seeing with private insurance, where you're seeing, $10,000 deductibles, I don't believe it's even remotely close to that am I correct with, in terms of Medicare, Medicaid?
You know, Senator, I do agree that there's going to be a variance in what plan is going to be offered. But again, this also goes back to the issue of whether or not, at what level of copay you're going to get. So depending on how your plan is designed, the general concern that we have with legislation like this is that it is going to encourage use of brand name drugs that where there are generic therapeutic or biosimilar alternatives available, which are covered under the formulary at a more cost-effective rate, and that legislation like this is going to encourage the use of a brand name pharmaceutical, which will ultimately drive prices up. So that's, again, cost concern is fundamental to kind of what our testimony is.
Yeah. No, and I understand this is a very complicated issue. I think this is a multifaceted problem that we're going to have to address. I think a lot of it is our nonprofit hospitals that, you know, there's no transparency and capability on the insurance side, but for anybody just walking in trying to receive care, you're looking at the pharmaceutical side on the crazy costs of a lot of these drugs. And how we can potentially tackle that, especially at the state level. But at the end of the day, I mean, the price, regardless, the end user, their deductibles. When I came into the legislature, you know, for a state plan, my copay for, you know, a family of 7 was only a couple $100, and it was a $600 copay. It is, I mean, my gosh, I wish we were back in those days. But if we're able to, I know it sucks. I mean, if these companies are willing to allow a coupon or a way to pay for that in hit on that individual, I guess, until we fix the bigger picture issue, I guess, what's your solution then?
Well, again, the solution is to allow for the PBMs to negotiate what these prices are and to not expose the private companies to the same issues that the federal government has already excluded itself from these coupons that get around that market transaction. Again, this, to me, is a marketing tool. You know, coupons are not forever. Coupons,
well, it's marketing to an extent, but they're also, I mean, the ones that are, especially if there's no generic, I mean, they're the lifeline, and if you're that person that your life depends on that drug, I guess, is it marketing?
Well, again, with respect to,
well, I mean, seriously, I mean, we just heard testimony of somebody that's potentially, you know, bleeding continually for months and months and months and months, and you know, and can't even carry on a normal life. I mean, if that's the only lifeline that you have, is it marketing? That's where, I mean, I don't know.
Well, and again, you know, to the extent that it does reflect that these companies can charge a lower price or negotiate a lower price for these medications that are essential to people, I think it certainly is reflective of that.
Yeah.
So that's kind of what my concern is.
Right. Now, thank you. I appreciate it.
Thanks, Senator.
No, I think piggyback off that, you know, we have to recognize also that there is a problem with the PBMs, right? So we will be having that discussion here in next week or so, but trying to get to a place, to Senator Bratton's point, where you're actually addressing some of the problems so people have access to the medications. If they're paying for their medication, if they have a deductible and they're paying that deductible off, why is it they're being penalized, you know, to be able to get a coupon from somebody else who's willing to help them with that? So anyway, we'll continue how to have the discussion. Appreciate the witness. Any questions? All right.
Senator, thank you so much.
Thank you. Appreciate it, Hampton. All right. Anyone else in opposition?
Hello, good afternoon. Mark Dalton on behalf of the Mid-America Carpenters Regional Council. Was mostly just in here to monitor, but I feel compelled to speak now since I've been conjured. But the main concern, and I think there was one witness earlier talking about affordability and profits. Plans like ours no one makes a profit from ours. There are no stakeholders. No one makes a profit on our plan. Our fund, every penny that we get back into it goes to the members. We are able to keep our coverage for all of our members consistent, because when we gather these coupons, that is spread across the whole fund, not just for those individuals that are bringing in those coupons and going towards their out-of-pocket max. So when we take those in, those savings are dispersed amongst everybody. So we keep everything equal for every member under the plan. And I know I was mostly just here to monitor. I mean, there is a lot of concern. I know there is an exemption for ERISA plans in here, which I do appreciate. The concern on that end is some potential erosions to the ERISA preemptions at the federal level. I do continue to travel to DC on that specific issue, because there has been some targeted attempts to erode the ERISA preemptions when it comes to PBM coverage. I know last year there was some oral arguments in a case that did bring the Supreme Court back to review the decision in the Mulready versus PCMA decision in the specific subject of, does the ERISA preemption, how does that relate to PBM coverage? So while I appreciate that it is in there, when there's also a fear of that erosion at the federal level, if we are excluded in this bill and then it's eroded at the federal level, we're right back in. And then also just the fact of, always cognizant of a divide and conquer when it comes to things like this. Let's pass this year, and then next year it's us at the plate. So with that, I'll take any questions, and appreciate your time.
I have a couple questions. So the structure for insurance through the labor unions is different than the average person who's trying to just has insurance on their own. So I just want to be cognizant of that there already is a difference. So I hope that alleviates. Nobody's trying to take that difference away from you, but obviously dealing with the issue of somebody who just has insurance, I mean, it's already different for them, right? So I want to make sure, though, that I'm getting conflicting information on whether or not the labor unions are carved out of this. So we want to clarify. But then I'm curious also, how is it the structure in these 26 other states that have this policy? Would you be willing to talk to us about that a little bit? Do you know?
The way that those work, I don't know the specifics in all the other states. If they do have specific ERISA preemptions in the wording, I don't know what the wording is. The way that our funds work in every other state are the same here. I am a trustee on our health and welfare fund. Every fund is set up and managed, and the plans are laid out and determined by those trustees. So when we have legislation like this and the other stuff that we see here in the building, those financial impacts are the plan determines how we maneuver, and some of that is we either increase the dollar amount contribution. For every hour that is one of our members work, there's a dollar amount that's pitched into our health and welfare fund. When legislation like this impacts our fund, we have to either increase those dollar amount contributions, which then lowers the amount of money our members make on the check, or we have to reduce the amount of benefits that we offer. You talk about some of the high-end pharmaceuticals. We have specific plans that our members will fall under for the very high-end pharmaceuticals that we lay out a plan for them, and this is how we're able to cover those. When the plans in some of these other states, again, I don't know the exact wording in the legislation and how that affects, but what it will do is those fund administrators and the trustees will sit down and say, okay, that this is going to increase the cost to our plan by X million. So what we're going to have to do is carve things out. And we start looking at, okay, are there specific pharmaceuticals that we just don't cover anymore under our plan? Or are there certain things that we need to change and reduce in the plan? Or do we just need to increase and take off of the member's paycheck, an additional amount to cover that cost. So it's just specific per plan, per state, and what the language is.
So help us honor the difference for you,
Correct.
that has your structured difference versus somebody who has insurance on their own. And then if you would help us, because again, as I look over these states, New Jersey, New York, I would assume that they're pretty labor heavy.
Mm-hmm.
How is it that they're structured so that they're not being negatively impacted because they just passed this legislation, I was told, in New Jersey. So would you help us navigate that?
Yeah, I will help you. And that, I'm not going to say that they were not negatively impacted. They could have been, and they're adjusting to it. Or they may have the preemption in there, and right now they're not impacted until the ERISA preemption potentially gets eroded, and then all of a sudden we are impacted.
Okay.
But yeah, I can definitely get that
If you
information.
and Hampton, maybe, I'm really curious about the information from the other states and stuff, so appreciate that.
Absolutely.
Any questions for the witness? Senator Lewis?
Good afternoon.
Good afternoon.
Thank you for your testimony. I think I've been, we've dealt with this when I was in the House, and the carve out, just for folks, 3 years ago, I think I was at a table with you and Jake and Zach, and we were with our caucus attorneys and their attorneys, and we kind of came up with this on page 3, line 6, and it wasn't acceptable, 3 years ago, the carve out. So it's something that's been like a work in progress. So I just want to point out that, this has been around for a while, but it wasn't acceptable for you all, way back when I was in the House. And I want to point out to the members of the committee that there was a letter from Zach Dunn with the laborers that was sent to all of us that he couldn't be here today, and he provides some details of his opposition as well. So just wanted, you're not in the hot seat by yourself.
That's fine.
It
Appreciate
hasn't felt too hot, has it? I mean,
No. For someone that came in here to monitor, this is, but it's still no big deal.
we pulled you in from monitoring to engaging, so that's always a positive
Always a
thing with
pleasure to
government,
chat
right?
with you guys.
All right. Are you, sorry, didn't mean to interrupt. All right, thank you. Any other questions for the witness? Seeing none, you're off the hot seat.
Thank you very much.
Anyone else here to testify in opposition? I think we need music as you walk up. Go ahead when you're ready.
Madam Chair, Shannon Cooper today representing America's Health Insurance Plans. And Senator Bratton, it might shock you, but I agree with about 90% of your previous statement about the healthcare world screwed up. And when we both came over here and were on the state plan, the premiums were way lower, the out-of-pocket expenses were way lower. Everything was more affordable. And that's just not the case today. And, out of every premium dollar we spend, 22 cents goes to prescription drugs. And that number has continued to increase. And, some people might want to blame the drug manufacturers. Some people might want to blame federal policy that forces them to spend billions and billions of dollars before they can get a new drug out there that helps these folks behind me, who I respect and appreciate for coming out today, and I understand the position they're in. But realize that 60% of the insurance plans that are sold in our state today are paid for by employers. And as a representative of the insurance industry, these employers come to us and say, we're trying to do the right thing. We are trying to have a good workforce. We're trying to keep them healthy. But these healthcare costs have skyrocketed. And what can you do to help us manage these costs so that we don't have to continue to increase the deductibles? We don't have to continue to increase the co-pays. And one of those tools that most health insurance plans use is a coupon accumulator, where those dollars are gathered to the benefit of the entire group to try and help manage those healthcare costs. Is it a perfect system? No, it's not. But the flip side is there's not a lot of areas out there where we can just go instantly lower the cost. And I hate to be Debbie Downer and act like my partner Nancy out here and be pessimistic, but without the renewal of the enhanced tax credits at the federal level, we're going to see a lot of people fall off the rolls of the marketplace. And when they fall off the rolls, that doesn't mean they no longer need health care. That just means they can no longer afford a policy. And then what happens is they show up in our hospitals in small towns, large towns, urban areas, and rural areas. And the hospitals are going to do the right thing and give them the treatment they need. But then they're going to turn right around and come back to us when we try to negotiate for those services. And they're like, hey, our uncompensated care just, it went up 20% this last year. So that means you folks that are doing business with us, you've got to help us cover that so we can stay in business. And I understand that. And it's a fine needle to thread, but we don't want to lose the ability to use programs like coupon accumulators to help and try and stabilize the cost to all of our other members in those plans. It might not be a perfect plan, but it's a plan that does help stabilize those costs. So, Madam Chair, and I know you're probably going to ask me about those other states that do this, and I would tell you that if I brought in a survey and said, hey, insurance has gone up 35% in the 26 states that have this, first thing you'd probably ask me is, well, what did you look at? I'm happy to look at what the average premium is across the nation and see if I can get you a chart that shows what we pay for in every state. But remember, a premium for a plan that has a $10,000 deductible is going to be much different than a premium for a plan that has a $1,000 deductible. So you've got to compare apples to apples. It's not just a simple thing of going out there and plucking one plan out of each state and saying, oh, this is the average cost. But happy to do that. Happy to stop talking and answer any questions you might have.
I think if there's a guy that can go out there and get the data and make sure we're comparing apples to apples, it would be you. And look forward to your ideas on how we might be able to help.
I will try and get this and deliver it to your office.
Appreciate
How's
it,
that?
and we'll disperse it. So, all right,
Thank
if you need a little bit of help doing that, I'm all in. So,
Okay.
All right.
Thank you, Madam Chair.
For your testimony. Any questions for the witness? Senator Bratton.
No, I totally agree. The prices have just went insane. And one thing I know that the president's, whether you like it or not, since the implementation of Obamacare or the ACA, the insurance growth has been United Healthcare's 1,200% increase to 2,000% increase approximately. Molina Healthcare, 1,000% increase. Humana, 1,000 to 2,000 is in between, just on the ebb and flow. Cigna, 800 to 900%. Centene, over 1,000% increase in stock value. So, I mean, we can sit here and cast blame, but I think the biggest thing is we've got to get transparency in every facet of this. I've brought it up on numerous occasions. My youngest daughter is 11 years old. I'll never forget getting our insurance bill, and this is through St. Luke's, now BJC. For me to sleep on the couch, they charged me $1,800 to my insurance to sleep on the couch.
Sir, I don't disagree. And
a natural birth of my daughter, my wife didn't. I mean, it was as natural as you could possibly get, just basically in a bed and a doctor assisting of a birth. Was $26,000. My mom, when she gave birth to me, it was $600, basically in the same hospital. $600 to give birth to me in the same procedure. I mean, so. There has to be some level of transparency, of which I believe there is zero amongst all, and that's why I'm not singling out the insurance. I know they're responding to the markets, but man, this is like almost, we have to go back to the drawing board for people.
I don't disagree, and I'm not going to say we're a perfect industry, but you touched on the pregnancy issue and the delivery costs, and when you can go in Missouri to one hospital and have a delivery for $20,000 and have that exact same delivery across the state, and they charge us $60,000 or $70,000. There needs to be transparency there. There has to be some kind of commonality to understand. You talk about specialty drugs. One hospital might administer it in the doctor's office for $500, and another one it might be $5,000. And these are examples of what goes on every day. And I think our constituents, the consumers, are completely frustrated with it. And it ruins people's lives. I don't disagree, and again, I don't, unlike some witnesses that want to disperse me, I don't disagree with the folks behind me. I tell everybody, if my child had one of these diseases, I'd probably be on the other side of this. But at the same time, I represent a ton of employers through these plans that are trying to do the right thing and manage these costs, and this is just one tool. But we'd love to have that transparency conversation and let everybody put their cards out on the table and see what's really going on.
Perfect. Thanks.
I think through transparency usually is how we fix problems, because it's hard to identify where the problems are when there isn't. So I appreciate the conversation.
Thank you.
Thank you, Senator Bratton. Any other questions for the witness? Seeing none, thank you.
Thank you very much, Madam Chair.
Appreciate it. All right. Anyone else in opposition? Sweet. All right. Well, I mean, I'm not seeing that. Informational. Anyone here to testify for informational purposes only? All right, great. Well, that wraps up the bill for Senate Bill 970, and I would like to make a motion that we adjourn. Second. All right, thank you guys. Why not?